Good afternoon, everybody, and welcome to this webinar. I'm Naomi Crafty, and I'm here with my colleagues, Michael Savage and Anthony Barnett, and we work in the clinical research and education areas at Turning Point. The topic of the webinar today is yesterday, today and tomorrow, the use of telehealth within behavioural health settings. We'd like to start by acknowledging the traditional custodians of the land on which Turning Point is situated, the Wurundjeri people of the Kulin Nations, and pay our respect to elders, past, present and emerging. We extend this respect to people from all First Nations communities across Australia and the Torres Strait and acknowledge that sovereignty has never been ceded. It always was and always will be Aboriginal land. Just a bit of housekeeping to start with. I'll be speaking for approximately the first 20 minutes of the webinar today, and I'll be providing some context about telehealth, both before and during the pandemic. And following my presentation, Tony and Michael will be providing the results of a recent study that they conducted with clients here at Turning Point. They were looking at how clients have experienced using telehealth during the pandemic. Registered participants will be sent a copy of my presentation and a summary report of Michael and Tony's research after the webinar. A recording of this webinar will be posted on the Turning Point website in about a week, and you, of course, are welcome to watch it again. Or you might want to direct some of your colleagues or other people you know to watch the recording on our website. If you have any questions during the live event, please enter them in the Q&A function. We will aim to have some time at the end of the presentation to answer questions, but please note that the chat function is disabled on this platform. So let's get started. As a psychologist who has taught counselling interventions for many, many years, I'm a fairly recent convert to telehealth. But since putting together a graduate certificate of telehealth, which Turning Point offers with Monash University, I've come to appreciate the breadth and depth of the field and the tremendous potential that telehealth has for reaching and helping our clients. So what is telehealth? Well, telehealth literally translates as healing at a distance, but it's a lot more than just what we see online or what we see in video conferencing presentations like the one that I'm giving at the moment. One definition of telehealth is the use of telecommunications technology such as telephone, video conferencing, internet, mobile applications to enhance healthcare, public health and health education delivery and support. But it's important to recognise that telehealth encompasses the whole sort of gamut and range of activities that we can deliver health information virtually or at a distance to other people. So it can include radio, television, print. Any website that delivers health information is a telehealth website. So it's really the delivery of health services over a distance. And of course, telehealth didn't begin in March 2020. In fact, telehealth probably has existed since the dawn of civilization. So since the time that we were able to communicate at a distance, and we can include in that sending smoke signals or drumming or carrier pigeons. So any way that we were able to deliver information to people at a distance, we could deliver health information to people. So you could argue that telehealth, excuse me, has existed as long as civilization has existed. And we should also remember that it's only in relatively recent history that the average person has had access to physicians or medical practitioners. So, around the time of the Middle Ages, only the kings had access to physicians. So if the average person wanted health information, then they had to, get it from somebody who spoke to somebody who spoke to somebody who spoke to the person who was who was providing medical information to the king. During the 19th century, there were rapid developments in telecommunications, and probably the first of these was the invention of the telegraph, which happened around the time of the American Civil War. And those of you who are my age might remember watching films like Gone with the Wind that showed some of the terrible effects of injuries during wartime in those times, and how people would use telegraph to transmit information to people who were then able to help the soldiers with their war injuries. So that's sort of one of the earliest examples of healing at a distance. The telephone was invented by Alexander Graham Bell in 1876, and the first published example of telehealth was in the Lancet in 1879, and that was a case where a child became sick during the night, and his parents, who had access to a telephone at that time, was able to contact a medical practitioner in the middle of the night, and they were able to have a conversation that led to treatment for that child. In the early 20th century, people were able to use technology to transmit cardiac sounds and rhythms. So it was the beginning of being able to use technology not only to have conversations with people, but also to collect health data from individuals. And as we sort of progress through the history of telecommunications in the 20th century, we see how those telecommunications have impacted in the use of telehealth. So in the 1960s, we see the development of telepsychiatry, which enabled remote counselling and the start of what we now think of as telephone helplines. And of course, this technology rapidly advanced in the early 2000s with the development of programs like Skype and various mobile apps that allowed us to communicate in a similar way to the way we're communicating today across screens. And the advancement of the field has just been massive in the 21st century. So somebody did a survey in 2017, and they were able to calculate that at that time there were over 325,000 health apps that people could access to get that provided health information, probably more today. The use of GPS and cameras allow us to collect a lot of data so that people can check for moles and skin lesions and things using telehealth. You can attach devices to phones like an e-stethoscope. So really, a lot of the information that we said you had to be in the same room as a medical practitioner to collect, you can now collect virtually over a distance. There are a whole range of different telehealth models that are available. So there's the one-to-one delivery in real time that we might think of primarily in telehealth. So being able to have a telephone or video conference type consultation with somebody in real time. But there are also group or peer-based programs, so online support groups. There's guided self-help that might use a combination of perhaps a workbook or an online program with facilitated conversations, either video or telephone. There's unguided self-help, so Dr. Google is an example of that, or the Better Health channel. So any program or video web page or internet site that we might access health information from. There's interactive or gamified content like fitness apps, and there's also asynchronous brief text-based messaging like the very effective COVID app. So there's a whole range of different models that sort of sit under the heading of telehealth. You're probably all familiar by now with the benefits of telehealth, so I won't go through these in any detail. We know that certainly prior to the pandemic, there were a lot of benefits for telehealth in rural and remote areas or during crises like the floods that we're currently experiencing. It's an opportunity for multiple health professionals to engage in a consultation with a single client, or for health professionals to communicate with one another. And there's also telehealth provides an opportunity for family members to join in health consultations. But there are other benefits perhaps that we hadn't thought about prior to the pandemic that we now know are very important in telehealth. The reduction in travel time for both health professionals and patients, increased access to specialist services, decreased stress of clients from having to navigate the service system. So for some clients, going to hospitals or finding their way through the service system can be very difficult. So if the system can come to them, then that's obviously an advantage. There's potentially a reduction in stigma, and I think Michael and Tony might talk a little bit more about that from their study. And also the opportunity to deliver services more frequently. It seems that telehealth is less intimidating and provides a greater sense of control for many clients. And very importantly, attendance and screening rates seem to be improved. So a lot of people who would normally miss appointments or not attend scheduled appointments are more likely to attend a telehealth appointment. There's a reduction in emergency department visits, which in a busy emergency department can definitely be an advantage. And people are able to stay in their homes and within their communities for longer, particularly the aged population. So we certainly know there are many benefits of this technology. The literature has pinpointed a number of facilitators of telehealth, things that make telehealth work better. We know that when the processes are well thought through, when telehealth is well funded, when the technology works, when we know who our clients are and who's able to benefit from it, when we're able to share success, when there are local champions, strong leadership, when there's good training, when there's assistance from a trained facilitator when things go wrong, when clients find the technology easy to use, when people have access to equipment or access to community hubs where they can engage in telehealth, when all those things are operating, then telehealth works effectively or more effectively. And of course, there are also barriers to telehealth in the literature. So we would all be familiar with the fact that if the technology is not working, then telehealth is unlikely to work well. Interestingly, there's quite a lot of evidence that says the more the people using telehealth believe it's going to work, including the practitioner, the more likely it is that it's going to work. So if you believe that your telehealth consultation is going to be effective, then it probably will be, and vice versa. And likewise, there are organisational barriers. If there aren't people within an organisation who are willing to lead the use of telehealth, provide the resources, who are ready to make necessary changes within an organisation, then it's also less likely to be effective for clients. We used to say that one of the barriers to telehealth, certainly in the physical health area, was the lack of physical touch or physical examinations, though the use of a lot of quite sophisticated technology is overcoming that barrier nowadays. There is certainly a cost of implementing the technology that needs to be dealt with, as well as providing sufficient infrastructure for providing telehealth consultations. If, as I mentioned, if a person doesn't feel adequate to deliver good telehealth, then they're probably not likely to do that. And there are still privacy, data security and confidentiality concerns that need to be sorted through. One of the biggest barriers to telehealth prior to the pandemic was the reimbursement barrier. So where GPs and other health practitioners were unable to be provided with reimbursement for their telehealth services, then of course they were unlikely to engage in those services. So we certainly found that once the government made changes to access to reimbursement for health practitioners for telehealth services, that this made a huge difference to the number of health practitioners who engaged in this area of practice. And I guess another barrier to the use of telehealth, which we're probably all familiar with, is a fear of using new technology. And certainly many health practitioners have this fear. And there are some very interesting statistics out there, particularly around GPs, who were quite quick to move to telephone-based telehealth consultations, but much slower to take on video-based consultations, I think primarily because of their lack of familiarity with the technology. So because of these barriers, certainly prior to the pandemic, we could argue that the potential of telehealth remains unrealised, in part due to the model being considered an add-on rather than being incorporated into business models and integrated with face-to-face practice. And I think what's interesting to see, and what we'll see in listening to Tony and Michael talk about their research, is how that has changed during the pandemic, where telehealth has become an integrated part of medical practice. In 2018, Mace et al. Did a study in the United States of behavioural health services using telehealth, and they looked at 329 organisations across the United States, and they found that people were using telehealth for this whole range of different types of activities. So I won't go through those one by one, but you can see it's not just something that's used for individual counselling. There are a whole range of activities that those of us who work in the behavioural health area can use telehealth for. In their study, they found that about 40% of services were using direct video conferencing, and then a smaller number of services were using telephone, mobile health, email, different types of monitoring devices, and store and forward, which is really about sending out messages to automated messages to clients or patients using SMS primarily. So this was the story before the pandemic, and as I said, a lot of the research that's coming out now during and after, as we come to the end, hopefully, of the pandemic period, will be really interesting to look at how this has changed. This slide shows the different types of providers who are using telehealth to deliver behavioural health services. I apologise for the misspelling of addiction counsellor. This is a direct, I copied and pasted this slide from the article by Mace, so the spelling mistake was in the original article. But you can see there that by far the biggest users of telehealth services in the past were psychiatrists, and that seems to still be the case during the pandemic. The most recent research I've seen in Australia has shown that psychiatrists have the greatest uptake of this technology, followed by mental health counsellors, social workers, psychologists, and then addiction workers. So I'll just end by mentioning that these are some of the services that Turning Point provide using telehealth. These services we have provided for the last 30 years, in particular the telephone helpline, so there's certainly nothing new for Turning Point. But I guess what is new is the fact that we have increased our use of these services and are looking particularly closely at what our clients think about those services. So I will now move on to my colleagues, Tony and Michael, to talk about their research that they did looking at Turning Point clients and their use of telehealth services.
Fantastic. Thanks very much for such a super interesting introduction, Naomi. You have made our lives a lot easier by introducing those key concepts. My name's Tony, as Naomi said at the start, and I work here at Turning Point in the clinical and social research team. A lot of the work we do provides in-depth accounts of both clinicians and consumers' experiences of new technology, such as telehealth. And along with Michael Savage today, we'll be presenting on some recent research we conducted, a study entitled Alcohol and Other Drug Treatment Clients' Experiences of Telehealth During the COVID-19 Pandemic. So I guess the way it'll work is I'll start by providing an introduction, then I'll hand over to Michael, who'll be discussing some of the initial findings, and then I'll come back on and discuss some of the insights that have emerged from our analysis. Michael and I are always very privileged to have such clinically relevant audiences, such as everyone tuning in today, and we'd be really interested in your insights and feedback. So if you don't have a chance to ask any questions at the end, feel free to get in touch. There's my Twitter handle and email address. So as Naomi alluded to, research on telehealth has increasingly become popular over the last few decades. Indeed, there's been entire journals that have been dedicated to telehealth research. And in this graph, we can see the rapidly increasing rise in the number of papers mentioning telehealth or telemedicine. Having said that, though, I guess you might say that one of the criticisms of this research might be that, generally speaking, it's had quite a narrow focus. Telehealth research has tended to, I guess, focus on simple outcomes or by asking research questions such as how do clients rate care delivered via telehealth? And often these types of narrow exploratory approaches don't take into account a whole bunch of other factors. For example, the context that people engage in telehealth in, its social impact, and also how engaging in telehealth might impact client-clinician relationships or the therapeutic alliance. Also, it's worth noting that a lot of the research on telehealth to date has looked at other fields of medicine like oncology or some of the more surgical professions, and not much has actually provided an in-depth exploration of alcohol and other drug clients' experiences of care delivered via telehealth. So that was the reason for the current study that I'm talking about today. We wanted to provide an in-depth exploration of alcohol and other drug treatment clients' experiences of telehealth during the pandemic. And specifically, we had two aims. Number one was to explore clients' experiences of telehealth during COVID-19 by focusing on things like barriers and facilitators to accessing care. And also how telehealth or engaging in telehealth influenced people's experiences and relationships with clinicians. Secondly, we also wanted to capture clients' preferences for how future telehealth might be structured and rolled out in the future. So in order to do that, I just thought I'd cover off some of the methods that we used. So we conducted in-depth semi-structured interviews with participants in Victoria. We ended up recruiting 20 people, and they had all previously engaged in telehealth during COVID-19. Interviews were audio recorded and then transcribed. And one of the, I guess, guiding theories that we wanted our analysis to be sensitive to was this idea that telehealth as a singular intervention, if you like, could have very different impacts or very different implications for people depending on their different circumstances. So this idea that affordances represent the represent the potential that a technology like telehealth might enable, constrain, or impact people's experiences of care in different ways. So we recruited 20 people, and I just wanted to present some of the participant demographics just to give you an idea of the types of clients that participated in the study. We recruited participants from a whole range of different services across the publicly funded drug and alcohol sector in Victoria. About 60% were male, with an average age of nearly 44 years, ranging from 34 to 66. Most of the people we interviewed had engaged in telehealth for individual counselling. And in terms of accommodation and also drugs of concern, there was a whole, people had experiences across a whole different spectrum, but also experiences that we do find relatively, I guess, reflective of clients that access care. Having said that, though, one thing I would flag is that all the participants in this study had actually experienced telehealth. So, yeah, I just wanted to flag that the findings might not be particularly relevant to people, particularly those who are marginalised, for example, those who might be experiencing homelessness or not have access to technology to be able to access telehealth. Their experiences might be different from the ones that I'm about to discuss. So what we'll do is, over the coming slides, we will present some participant accounts and some quotes from the actual interviews. Before I go on, I just wanted to provide a very quick high-level overview of the findings. So we have 3 columns here at a high level: context of telehealth care, experiences of telehealth care, and also clients' preferences for future telehealth. So shortly, I'll hand over to Michael, and he'll be looking at this first theme, and then I'll unpack in further detail clients' experiences of telehealth and also preferences for how future care might be rolled out. But without further ado, I'll hand over to you, Michael.
Thanks so much, Tony. Thanks for having me here today. It's a privilege to be presenting as part of this webinar. So as Tony said, I'll focus on one particular aspect of our findings, the often overlooked context and preparatory work that clients do to use telehealth comfortably. So as the headline on the screen suggests, the rapid implementation of telehealth during COVID-19 was imbued with the hope that people, including people with alcohol and other drug concerns, could easily and flexibly access healthcare from the comfort of their own home. But things are rarely so simple or easy as we all know. And so today I'll talk through 3 themes for our interviews about the work that clients do to try and facilitate comfortable telehealth contexts and experiences. I suppose the first thing to say is that we noted how much work clients were doing in telehealth sessions as service providers sometimes struggled with telehealth during the pandemic, and especially during the initial stages of the pandemic. So for example, Don, a client here, says, "I'd set up all of the Zoom and everything. I was actually using my own account for the first couple of sessions because within the organisation, they hadn't sorted out all of their Zoom and everything." So while we know that clients and technology do work in any care encounter, services would generally be doing more of the work of providing access to in-person care spaces in pre-COVID times. And certainly, as the pandemic wore on and services got more acclimatized to using telehealth, that was certainly the case. With this in mind, I'll now explore how clients tried to cultivate spaces and times that afforded comfort and privacy, but as you'll see, that didn't always eventuate. So as you can see on the screen, many participants talked about selecting a comfortable and private space in their home if they had one for telehealth sessions, and that was often a bedroom, as Lucy here says. But participants who lived with other people often engaged in negotiations of planning to secure private spaces at particular times for appointments. So Tanya warned her parents that my counsellor is going to be ringing and it's going to go for about 45 minutes. This is the time frame. So no, there were no privacy issues there. So here we can see how securing a private space and time involves the goodwill and agreement of household members, which may or may not always be forthcoming. While the home did enable comfort and privacy to be realised in some circumstances, this wasn't always the case. Here Amanda says, If I was inside, I was scared my kids would hear my telehealth session, but if I was outside, my neighbours are going to hear me. So Amanda went on to talk about how the lack of a private space inside or outside of the home resulted in uneasy telehealth encounters where she was preoccupied with being overheard. The discomfort and lack of privacy of home led some participants to cultivate more comfortable spaces for telehealth outside the home. Here Zane says, I've got my son and his mother staying with me at the moment, so usually to get some privacy, I just come out and sit in my car and just do a phone from there. And obviously the availability of car spaces depends on having a car and a range of other factors. Where appropriate house or car spaces weren't available, participants attempted to find secluded public spaces for telehealth sessions. So here Ray says, I end up taking a lot of calls in parks around the city. I've actually found some really cool little spots around. There are a couple of times I had an issue finding a secluded spot, but I've got headphones that I can speak into though, so it's not a huge deal. So while Ray found secluded spots with some help from his headphones, seclusion does not always materialise in public, as he says. And we also know that lockdown restrictions may have also constrained opportunities for accessing those public spaces depending on kind of restriction situations. But unlike Ray's experiences, which also involved careful planning and preparation, Sarah says, it's happened a couple of times where I've been out doing shopping or an errand or getting food, and I forgot I had a telehealth appointment, and I had a quick chat to them and just kind of ticked the boxes and hung up. So forgetting appointments, as we all do, particularly while in public, led to uncomfortable and unsatisfying telehealth sessions. But sometimes comfortable telehealth encounters did not emerge despite participants' best intentions and work, highlighting the fragility and precarity of telehealth. For example, James, who lived in a rural area, described how he would drive about 30 minutes away from his house to get phone reception to attend a telehealth appointment. And even then, he says, it might sound odd, but telehealth depends which way the wind is blowing. Depends if there's clouds, depends if it's dark weather, depends if it's just, I don't know, bloody Telstra not working. Just quite unpredictable. As James suggests, it's sometimes difficult to get all the elements of moving parts working well. So in the accounts presented so far, you may have noticed the number of objects that clients gathered into telehealth sessions and sometimes help them to produce those comfortable telehealth encounters, but not always. This included things like phones, computers, furniture, cars, blankets, headphones. And I just wanted to highlight some additional objects at work as we go along. One of these is clothing, or as Don says, I made sure I wasn't just in lounge around clothes. I actually put on a certain outfit to wear, like I was going out. When I was on telehealth, I would act like I was going to an in-person appointment anyway, because it helped me to stay engaged. So here, non-lounge around clothes, among other things, enabled the production of a situation similar to an in-person appointment. Not necessarily about comfort, but about priming for therapeutic activity and engagement, getting people ready for what was to come. Other objects were also involved in practices that participants engaged in to manage the anticipated unease that accompanied some care encounters. So being at home afforded participants those opportunities to engage in different everyday practices that they might not have been able to do otherwise during an in-person appointment. So here Kate says, at times if I get anxious, I'll walk around and I might put some washing on or something like that, something quite mundane, to try and take the focus off some difficult conversation and the different topics that I found hard. A few participants also described how telehealth afforded opportunities to consume drugs and other things. For example, Amanda says, it was lockdown, so I had my kids at home. So I'd just have a tea and then I'd make some joints and smoke them and talk to the counsellor while I was stoned to calm me down. So we know that drug consumption before or during an in-person session is often discouraged or can even result in care being stopped. However, audio-only telehealth formats, along with home spaces and the lockdown circumstances, enable people to continue to be availed of care, even if they just consume drugs. For Amanda, this cannabis consumption before or during the session did produce multiple effects and created somewhat of an unresolved dilemma. On the one hand, she says, I can talk and go deep in stuff when consuming cannabis, but like the whole point is for me to stop. And if I'm smoking, then telehealth is not really as helpful. So I think I might leave it there for now, but there's plenty to talk about. I'm happy to hand back to Tony, and happy to chat through anything I've presented further as desired.
Fantastic. Thanks very much for that, Michael. So that's a really neat and insightful summary of that first theme. So I'll now sort of delve into the second and third, firstly starting off with looking at some experiences of care in more detail. So I guess it's fair to say that across the data set and across the people that we interviewed, mainly telehealth was experienced as convenient and easy to access. For example, as Tanya said, she said, with telehealth, with Zoom, you still get to see your worker and interact. Having said that though, in order to establish a strong clinical relationship between client and clinician, some participants thought that it was really important to have at least one in-person appointment if possible, which was sometimes no doubt difficult with the rapid onset of the pandemic and the move to telehealth from in-person care. And that's represented in Jen's account when she said at some point, somewhere along the treatment plan, there does need to be at least one in-person appointment, because an assessment that can't be made wholly and solely on telephone. Having said that though, care was experienced in different ways by different people, depending on their individual circumstances. For example, for Lucy, care via telehealth was experienced as engaging and supportive. She reflected on her experience by saying, telehealth still felt like it was my intimate counselling session and not like it was just a conversation on the phone. It was better than what I thought, because I thought it was going to be weird on the phone, but it was just like I was seeing them face to face. Having said that though, not all participants echoed that same sentiment. For other participants, telehealth posed a particular challenge for maintaining or building a therapeutic relationship with clinicians, especially when people felt they were not seen nor heard in the same way as they might be in in-person settings. For example, Kate said, I just didn't feel connected with that person. You can't see my body language when we're on the phone. And on that point, in relation to body language, a number of participants stated that, their experience was optimised in telehealth care, if telehealth care was delivered via video, where they could be seen, so video rather than telephone. And that's represented in Jane's example when she stated, like, the clinician can't access my health via a telephone. Do you know what I mean? He can't see whether I'm yawning. He can't see whether there's tears running down my face. You can't see whether I'm in withdrawal or not, and if I've lost weight. Do you know what I mean? So moving on to the final theme that I'll be presenting today, all about clients' preferences for how future telehealth might be designed in the future. There are a whole range of perspectives, but I just wanted to focus on a couple of things today. Participants generally wanted more information about what telehealth might involve. And an example of that was Lucas's account when he stated, a questions and answer sheet that says, hey, we're going to have this telehealth. How long does it run for? How does it work? You could have all this on a fact sheet and you could work through a little checklist. So this Lucas's sentiment was echoed across other clients' accounts in the study. It was really viewed that a quick reference guide or information on a website would be really helpful. Also, if a website had links to different telehealth or phone numbers for different services would be helpful, because you can imagine if a client is engaging with multiple healthcare organisations, it can get quite difficult to managing Zoom links and stuff like that. So if there could be a one-stop shop, if you like, for lack of a better term, with client information, that was viewed as potentially really helpful. The other theme that I wanted to discuss today was in the future, many participants thought that a hybrid model of in-person care combined with telehealth would be really favourable and promote treatment engagement. And Charlotte, as she stated, she said, I think a mix of telehealth and in-person is important, depending on what the client wants. Yeah, I think that should be tailored to a person's specific needs for it to be able to be flexible. And within this notion of flexibility, one key element of a hybrid model was the idea of choice or consumer engagement, if you like. And that is, I guess, where possible, really giving clients, taking a consumer-focused approach, giving clients the choice of how to set up a telehealth program that suited them. So Michael's presented some of the findings along with what I've just wrapped up there, clients' preferences. We just thought we'd cover off some of the key insights that have emerged from our analysis. And in a minute, I'll send you a link to a report where you can get more info on this. The first thing is it's really clear that different clients have different experiences depending on their context, and that might be the types of technology they have access to, the types of alcohol and other drug concerns that they might be accessing care for, and also whether or not they have a pre-existing relationship with clinicians. I guess one of the big questions that we're still toying with, if you like, and we'd be really interested to hear your thoughts and questions in the Q&A. The idea that it's critical to resource people for and prepare them, if you like, for the preparatory labour and objects that are involved in setting up a telehealth encounter. This could include devices or other objects that might enable a strong telehealth service connection. If people's contexts aren't conducive to telehealth, then we also think building in flexibility and indeed allowing exceptions to service and government policies might be useful for particular clients. And one example of that is if telehealth encounters can't occur in the home or in public, then perhaps allowing people to utilise service spaces or equipment might be useful. The notion of hybrid care was really important in our analysis, and as I said, the idea of choice. So really engaging clients and following a mantra of consumer-led care in order to, where possible, design hybrid in-person and telehealth, a mix of services being made available. Clearer information about how clients might connect with telehealth was viewed as really important. And perhaps something that you might like to reflect on within your own service is by asking the question, are we ready to switch to telehealth if in-person was suspended again? And what might that look like in terms of different types of technology, video, phone, SMS systems, and so forth? And as I alluded to earlier, it's really important, just as a general principle of maintaining health access and equity, by ensuring that clients across a whole spectrum of different experiences, ranging from those who are particularly marginalised to those who already have supports, making sure that with telehealth rollout that people from a health equity perspective still have access to care. So like I said, if you'd like more info, we've written a summary report that captures what I've discussed today. And I think the workforce development team will send out a link to this. And on that note, I just thought I'd like to make a few thank yous. Thanks very much for all the participants who were very generous in their time. Thanks to the workforce development team for facilitating today's webinar, and to the funder, the Department of Health. Thanks very much.
Thank you so much, Tony and Michael. Great research and really interesting looking at, I think I particularly love a lot of the qualitative data that you've got and really understanding what people are thinking about their telehealth experiences, but also looking at how this changes over time. I suspect that, and I'm interested to hear what you think about this, but I suspect, like almost everything else in life, the more practice we have and the more comfortable we feel with a particular way of doing things, the easier it's going to become for everybody. And so somehow I think that whether it's 2, 5 or 10 years from now, looking back on this time, we're all going to sort of smile to ourselves and say, remember when telehealth was this thing that we discussed whether or not it was going to, actually catch on. And now the idea of making people sit in traffic and sit face to face with one another in an actual clinic setting seems so passé. That's sort of where I sort of see things heading. But I also think that the hybrid concept, and it's almost seems to me with every new technology that's been developed, we haven't necessarily thrown out the old technology, but we've learnt to use different technologies simultaneously in a way that's sort of advantageous for whatever it is that we're doing. So, it will be really interesting to see how this story unfolds over time. Just while we're waiting, perhaps for a few people to ask some questions, I just wanted to mention that Turning Point, our clinical services, have put together 2 fact sheets. There is a fact sheet for practitioners on how to set up your telehealth practice, and there's a fact sheet for clients about what to expect with a telehealth consultation. Obviously, these have been tailored specifically for Turning Point, but again, I might get Marion to send these out to the participants of this webinar so you can have a look, but they are also available on the Turning Point website. We have got those fact sheets, and you might want to adapt them for your particular service. So I've just there have been a couple of questions and comments. Somebody asked about access to the slides, so we will be sending out my slides and a summary of Tony and Michael's research at the end of the webinar. Somebody asked me how mobile health was defined in the MACE article, and the answer is I don't know, but they did differentiate between video consultations, telephone consultations, and mobile consultations. So I'm suggesting that, maybe the mobile were things like SMS or consultations where that information could be transmitted at any time as a person is sort of wandering around the world, as opposed to fixed consultations that occur within a setting where somebody used video or telephone, but it's not specifically mentioned in that article. Sue has made a comment. I've worked with a few women over the past 2 years who have never met me, generally employed women, and I've had some very strong positive feedback. Interaction was phone only as well with these ladies. So I couldn't agree with you more, Sue, that I think that it is quite possible to have really good both phone and video consultations with people and not necessarily meet them in person. And I think that will happen more and more as time goes on. Tony and Michael, please pop your hands up and wave at me if you want to add anything as I'm talking. So there's a question here. Did the research demonstrate that telehealth was a desired means of treatment going forward? Our organisation is pushing for us to offer face-to-face as the preferred service provision. Would either of you comment?
Yeah, I'm happy to take that one, Mary. Yeah, that's a great question. As Tony kind of pointed out, there was a strong preference for that, for kind of a range of options going forward, including both telehealth and in person. We did a survey of 30 people as well that we didn't present the data from, and just to give you a sense of the numbers behind that, I think about 74% of people indicated a preference for flexible options in which telehealth appointments could play a role. So we had very few people that said, I really want telehealth only, or I really want in-person only. Most people said they wanted some combination of the two, and I think that fits quite neatly with that idea of a hybrid model and giving people the choice and flexibility to engage in the way that they would like to feel most comfortable and are able to access the most easily.
I'm very interested in this idea about people self-selecting what type of service they want to provide. So there is this argument that people who would prefer telehealth options should be allowed to select telehealth options, and people who prefer coming in face-to-face should be allowed to come in face-to-face. And I just have some concern about that, because I think that people don't necessarily select the options that are best for them. Sometimes they do, but maybe there's a concern that people who have social anxiety or who have difficulty in face-to-face interactions are more likely to want to do everything from home. And in that case, is that actually in their best interests to keep them in the home or to keep them from physically interacting with people, or is it better to take people a little bit outside their comfort zones? I think it's probably an empirical question, so I think there might be some research in that area that might look at not only whether people should self-select what type of treatment they want in the future, but also whether there are certain people that might be better suited for different types of treatment or combinations. An interesting question for the two of you. If you did this research again, what would you do differently?
I'm happy just to make a couple of comments there. So, and someone else has actually raised the point about has there been research on clinicians' experiences of telehealth? There are a few groups that are looking at clinicians' experiences within the AOD sector, but having said that, though, there's a lot of research about clinicians' experiences in general, and perhaps I can update the workforce development team with a few links to those studies as well. How would we do it differently? It was actually challenging to recruit people, given COVID-19 and so forth. So yeah, it'd be interesting because we did the study during COVID-19, or during the peak of the pandemic, if you like, when services were closed. I guess it would be interesting to do some further research on sort of longitudinal, about how, as services slowly open up, about how people's experiences have been impacted. Definitely as well, and I will get the workforce development team to send a link to this particular study. As I alluded to earlier, there are other groups that that do access care and within society, particularly those who are experiencing homelessness and so forth, who might have experienced some harms or great difficulty in accessing any sort of care when in-person was closed. So I think that's obviously a really, really important group to do some research with, in order to ensure that, with the rollout of telehealth, that they're still able to access care and supports and so forth. So yeah, those are just a couple of insights, but I'll get the workforce development team to send out a link to some other research, particularly around clinicians' experiences of telehealth.
And in that same vein, somebody's asked the question, what we think about the reason for psychiatrists being the major uptake of, being the group that have taken up telehealth more than anyone else. That I might just add that particular research that I was looking at there was United States-based research. But having said that, I have seen some research here in Australia that also showed that psychiatrists were the leading professional group for the use of telehealth, followed pretty closely by psychologists, certainly during the pandemic, but not so much before. I think if you go back to those things that I put in my slide, which you'll be sent after the webinar, about the facilitators of telehealth, I think that might explain it. So why psychiatrists might be particularly, might have been particularly quick to take, or particularly advanced in taking up telehealth, was because I think it was very much encouraged by their professional organisations. I think they would have been paid a reasonable amount of money to engage in telehealth consultations. I am aware of a man called Peter Yellowlees, who's a leading researcher in this area in the United States. and he has really promoted telepsychiatry in the United States. I think it's about self-efficacy and the efficacy of the profession to use that particular technology. And also, looking at what your colleagues are doing. We do know there's a massive shortage of psychiatrists and specialist psychiatrists, certainly in the addiction area, but more broadly in society. And so where there's a shortage of specialists, then coming up with solutions like telehealth is sort of likely to be seen as a good option. So I think perhaps all those facilitators that we talked about existed for that profession more than any other pre-COVID. Let's have a look at some other questions we might have here. There was a question about children. I think here at Turning Point, we don't, we're not involved in any clinical services with children. So I guess there would be other people. That's a webinar for somebody else to do in the future in that area. Another question. Did the study consider any challenges in regards to managing risks during interactions with clients using telehealth?
That's a great question, and I think potentially something that, one of the studies that Tony mentioned, or a future work, kind of looking at also clinician and provider kind of responses would really, I guess, be enlightening in respect to that in terms of how services manage those risks. And but it is a big issue, and one that needs some careful thought, I think.
Yes, so I just might add to that here at Turning Point in the workforce development area, we have run a number of workshops that have looked specifically at managing risk, and we are certainly very aware that this is an area where there needs to be more professional development and education. So for those of you who are particularly interested as to best practice in terms of managing risk during interactions using telehealth, please look out for some of our one-day workshops that where we'll be covering that area. But I suspect a lot of people were sort of flying by the seat of their pants in over the last couple of years, and there'll be a bit of catch up in the next couple of years in terms of best practice and how to really do telehealth safely and effectively. I think we're getting on to 2 o'clock now and the end of our webinar time. So thank you so much to everybody who has logged on and listened to what we had to say. And I do hope that you will continue to look at our other Connect and Learn webinars. Thank you so much to Tony and Michael for being my colleagues and joining me today for this webinar. And we look forward to part 2 and part 3 of your research off into the future. So thanks very much, everybody, and see you next time.